So I'm very happy to be among you this morning, and first I wish to wish happy birthday to ISMINIM, and I'm coming from Tunisia. Tunisia is a little and very beautiful country in the north of Africa, and I invite you all to visit it if you have the opportunity, and we will be welcome. So, first, prima non nocere, say a well-informed surgeon should not confuse his ability to perform an intervention and its indication. You all know that the responsibility of fibroids in infertility remains until today unclear. And today we are faced to a dilemma. On one hand, myomas are associated with a high infertility rate. And on the other hand, myomectomy generates complications which compromises fertility. So my aim today in this topic is to define the involvement of myomas and myomectomy in infertility in young women. So what about prevalence of myoma in the African continent? It is very frequent, and in many regions it is over 70%. It depends on age, on ethnicity, and on techniques of diagnosis. And what about fertility prevalence in women with myomas? Since 30 years ago, Hassan reported 43% of women with fibroids which had an infertility over 2 years. And our recent study in my department in Tunis confirmed, we conducted a prospective study comparing 80 infertile women with myomas to 80 infertile women without myomas, and conception rate was significantly lower in group 1. This relationship between myoma and infertility is explained by endometrial alteration and uterine vascularization dysfunction. These modifications should explain the negative impact during all fertility steps like fecundation, implantation, embryo transfer, and miscarriage. This miscarriage, frequency of miscarriage and myoma, this association varies from 3 to 13% and reach 20% in WRA with submucosal myomas. So the second part of my topic is the influence and the impact of myomectomy on fertility. For that, we conducted in my department a retrospective study about 120 myomectomies and a systematic open laparoscopy 3 months after laparotomy or laparoscopy. And we did a systematic ambulatory hysteroscopy 2 months after hysteroscopy resection. As you see on this table, the half of population had an hysteroscopic myomectomy, 30% laparotomy, and 20% laparoscopy. All these myoma are symptomatic, and we see that our global adhesion rate was 75%, varies from 52 after laparoscopy to 92% after laparotomy for large multiple myomas. And we found also a close relationship with the size, with the number and localization of fibroids. Our results is the same of Hertz results. Nevertheless, we respected rules to reduce adhesions like limited sutures, abundant irrigation, ablation of necrosed tissues, and using barriers and anti-adhesion gels. About this subject, Ahmed did a Cochrane review about the 16 study, and he confirmed that the use of anti-adhesive gels and barriers significantly reduces adhesions risk. Synechia is the most and the main complication of hysteroscopic resection, and we had a risk of 45%. We can prevent it by bipolar energy, which reduces this risk to 7.7%, and hyaluronic acid gels, which reduces risk to 5% for polypectomy and 16% for myoma resection. What about the impact of myomectomy technique on fertility? For the hysteroscopic myomectomy, most randomized studies report an improvement of fertility following hysteroscopic myoma resection compared to abstention. Cassini conducted a randomized essay comparing open myomectomy to abstention in infertile women, and he didn't find any improvement of pregnancy rates after open myomectomy. There is a meta-analysis, a meta-analysis about 6 randomized trials comparing open myomectomy and versus laparoscopy, and he reports significantly less blood loss and postoperative pain in laparoscopy group, but a higher operating time during laparoscopic myomectomy. In our study, we found less adhesions compared to laparotomy. So why some surgeons persist yet to do myomectomy phase 2 asymptomatic fibroids? To preserve fertility? Surely not. To reduce complication risk during pregnancy and childbirth? To anticipate complications related to an increase in myoma size, or to exclude malignancy? For the last argument, sarcoma risk, as our colleague said, is about 0.1%, and it is lower than that of death attributed to hysterectomy. That's why Anglo-Saxon didn't recommend myomectomy in this indication. As it is impossible to predict either the growth of myomas nor their potential to become symptomatic, prophylactic myomectomy does not seem justified. And the argument of myomectomy to preserve fertility, there are currently no consensus to advise WRA with large interstitial asymptomatic myoma on the best attitude between waiting and surgery. So anyway, patients with asymptomatic myomas must be informed about myoma's impact on fertility as well as the scale benefit risk of the surgery. So in my department, informed and signed consent is mandatory in our daily practice. So I have 3 take-home messages to give you. The first one is to better advise a patient with asymptomatic myoma wishing to preserve her fertility. We should consider her age and also location and size of myoma. The second message, it is not recommended to perform a preventive myomectomy for an asymptomatic interstitial or subserous myoma. And the last one, hysteroscopic myomectomy of submucosal myoma in women in reproductive age seems justified. So we sincerely think that HIFU should be, seems to be the compromise in this situation. And the issues with HIFU in African context is, are so expensive. The cost is the issue, and the skills requires long-term training. And we need more randomized studies about fertility following HIFU procedures to encourage doctors to accept it. In my conclusion, myoma diagnosis need to consider the responsibility of myoma in infertility, but also its impact on a future pregnancy. The therapeutic management is based on myomectomy, but expected benefits must be weighed with the potential risk of myomectomy. And last, HIFU therefore imposes itself as a rational alternative to this dilemma to preserve fertility in women in reproductive age. And in Tunisia, we are on the right track to introduce this procedure in Tunisia. And finally, I invite you to attend the next FIGU World Congress of Gynecology and Obstetrics in October in Paris. Thank you very much.